right, thank you so much, everybody, for coming on this Saturday. I'm going to be talking primarily about the genetics of multiple myeloma. This is a very complicated area, and I think at the end of the day, if you take home, the knowledge that the genetics of myelomas is incredibly complex, that this has implications with regards to personalized medicine, I think you're doing well. But importantly, too, the genetics also plays an important role in prognostication of multiple myeloma, and we'll talk a bit about that as well. So I think what I'm going to go ahead and do, So we're going to talk a little bit about what myeloma is, but again, as Greg said, this is a graduate level course, so I'm going to move through that fairly quickly, as well as the baseline testing. I think a lot of you know what sorts of tests are required, when you're initially diagnosed with multiple myeloma. But we're going to spend most of the time talking about the genetics of multiple myeloma. So we'll be looking at the chromosomal changes or cytogenetic changes in multiple myeloma and what the clinical relevance of those cytogenetic changes are. We'll be talking about gene expression, what's the implications of genes being turned on and turned off, and the pattern in which genes are turned on and off, and what the clinical significance of those issues are. And we'll also talk about mutations at the DNA level as well in oncogenes and tumor suppressor genes that are important for the propagation of multiple myeloma. And then at the end, I'm going to talk about standard and high-risk disease, in the context of the cytogenetic gene expression profile and mutational changes that occur. So you all know what multiple myeloma is. It's a cancer of plasma cells. What the heck is a plasma cell? So a plasma cell is a white blood cell that resides in the bone marrow and produces antibody to fight off infection. So if a plasma cell, over the course of time, and we're talking many, many years, acquires the right set of chromosomal changes and gene mutations, it will start to grow in an uncontrolled manner and lead eventually to the manifestations of multiple myeloma. So what are those manifestations? So we see clinical manifestations of multiple myeloma due to growth of myeloma cells in the bone marrow. So we all know about the anemia that it can cause, bone disease, which can be manifest as bone pain or pathologic fractures of the spine or long bones, high calcium levels. We see suppression of normal plasma cell function as a result of multiple myeloma. So the levels of normal antibodies will be low, making patients vulnerable to infection, especially pneumonias and other respiratory tract infections. And the antibodies that are produced by the myeloma cells themselves, while it serves as a good biomarker for monitoring response to therapy over the course of time, those antibodies can also be destructive in and of themselves and lead to kidney failure in the form of what we call myeloma kidney or cast nephropathy. There are some other unusual kidney failure manifestations that antibodies can produce. Sometimes the antibodies made by the myeloma can bind to peripheral nerves and actually cause neuropathy in and of themselves. We think of neuropathy as a result of the drugs that we use to treat myeloma, but you can actually have neuropathy from the antibodies that are produced by the myeloma as well. If the antibody being made by the myeloma is mutated in such a particular way, the physicochemical properties of that can actually allow it to fold in an unusual manner and accumulate in organs over the course of time, causing a condition called amyloidosis, which can affect the heart, the gut, the liver, nerves, kidneys, etc. And if the antibody levels are really high, especially if you have an IgA or IgM myeloma, you can have symptoms and manifestations of what we call hyperviscosity syndrome. I keep wanting to advance the slides with this, but I realize that we can't do that. So we know that multiple myeloma starts with a precursor disease called monoclonal gammopathy of undetermined significance, or MGUS, a name that I've never really liked. From MGUS, we go on to smoldering multiple myeloma, which is multiple myeloma without the organ manifestations of the disease or imminent organ manifestations of the disease. And then we go on to active multiple myeloma in of itself. Now, from a biology perspective, there are what we call initiating events that are present at the level of MGUS. So there are certain chromosomal or cytogenetic abnormalities that are present right from day one when the patient has MGUS. And these can be divided broadly into two categories. One is what we call hyperdiploidy, where there's an excess of chromosomes in the myeloma cells themselves. And then there are what we call IGH translocations. You'll see us refer to IGH translocations a lot. And what that is this 14 that you see in these parentheses here. So on chromosome 14 is an immunoglobulin heavy chain gene, and that is the source of a lot of the translocations or juxtapositions of different chromosomes in myeloma. So we'll have the 414 translocation, the 614, the 1114, the 1416, and the 1420. Just a couple of highlights here. The 414 translocation, the 1416, and the 1420 translocations are viewed as high-risk cytogenetic abnormalities, as I'll talk about in a little while, whereas the translocation 614 and 1114 are not felt to be high-risk markers. Now, we'll be talking a lot about 1114 translocated multiple myeloma during this session, because as it turns out, this specific subset of myeloma is more exquisitely sensitive to a BCL2 inhibitor called venetoclax, and you'll hear more about that as we go on. Now, as MGUS transitions to smoldering multiple myeloma and then to active multiple myeloma, you see what we call secondary changes at the chromosome level, but also at the gene mutational level as well. And good examples of this would be what we call gain of 1q. In other words, this is extra copies of the long arm of chromosome 1 that accumulate over the course of time. You can actually see missing portions of the short arm of chromosome 1 as well as a secondary change. And then one that a lot of you have probably heard about is deletion 17p, or in other words, missing chromosomal material from the short arm of chromosome 17. And all of these confer more aggressive disease biology, a more proliferative myeloma when they occur. Over the course of time, you may see chromosome 1q amplified even further. We might start to see what we call c-MYC translocations, and we might see what we call biallelic deletion of certain tumor suppressor genes. So a patient with deletion 17p, one left intact p53 gene will become mutated and inactivated. And when that happens, when all of these high-risk markers accumulate, we wind up with high-risk multiple myeloma, which can be manifest as plasma cell leukemia, where you see a large number of myeloma cells circulating in the bloodstream, or what we call EMD, or extramedullary disease. Now, there are important bone marrow microenvironment factors and immune system players that also influence how the myeloma biology behaves over the course of time, but just for the sake of time, I'm not going to be able to address that during this talk. So these are the basic diagnostic tests at baseline that everybody should get. I'm just going to highlight a few. It's absolutely critical that you get the beta-2 microglobulin and albumin to determine your international stage. LDH has prognostic value, and oftentimes that's missed, especially if a patient has been worked up in the community setting. A bone marrow examination, biopsy is absolutely critical, where we do conventional karyotyping, where we actually look at the chromosomes, how they look under the microscope. There's FISH testing, which are specific probes to identify specific chromosome abnormalities in the myeloma cells, which is a much more sensitive test than conventional karyotyping to determine the chromosomal changes that may be occurring in myeloma. Generally speaking, we would never advocate that you just get conventional karyotyping alone. You have to have the FISH testing, and you have to have the appropriate markers probed for. There's a lot of different myeloma FISH panels out there. Some of them are very good and cover all the high-risk markers. Not every single one does. Imaging is absolutely key. Now, in the past, skeletal surveys or plain radiographs of the entire skeleton was what we typically did. But more and more, we're doing whole-body PET-CT at baseline as well as at follow-up, and that has implications with regard to durability of remission, and then certainly CT or MRI imaging as dictated by signs and symptoms. So these are the diagnostic criteria for MGUS, smoldering multiple myeloma, and multiple myeloma. I'm not going to get into the details of this. I'm going to focus more on the genetics, as I said before. So what kind of cytogenetic abnormalities might we see in myeloma and in cancer in general? So we have what are called copy number alterations, or CNAs. So this might consist of a chromosome deletion. And again, the perfect example of this is deletion 17p. And there's a tumor suppressor gene on 17p called p53. And we think that dropping out is the most important biologic event as a result of the missing portion of the short arm of chromosome 17. You can also see chromosomal gains in myeloma cells. And the really good example of this is gain of 1q. And we'll talk a lot about that later. Chromosomes can be abnormally fused together, and what will sometimes happen is you'll actually get two genes that are fused together, which leads to a novel protein with oncogenic function. But also what will happen is that sometimes genes will be juxtaposed to what we call enhancers, or promoters that allow their expression to be ramped up significantly. And a good example of that, again, going to the 11-14 translocation, what that does is it brings the cyclin D1 gene right juxtaposed to the promoter of the immunoglobulin heavy chain, which leads to a significant, robust production of cyclin D1. This is the chromosomal or cytogenetic landscape of multiple myeloma. So as I said before, you can break this down into two broad categories. So you have the patients who have extra copies of chromosomes, trisomies, or hyperdiploidy, and that occurs in about 42% of patients. This is Mayo Clinic data. You have the IGH translocations that I've already talked about. Those occur in about a third of patients. You actually will, these are usually mutually exclusive, but 15% of patients will have both hyperdiploidy as well as IGH translocations. And then, only a very small number of patients will actually have a normal cytogenetic profile. So if your FISH testing comes back completely normal, the question is, was it a good sample? So, but if you're in remission, it should be normal. So just to let you know. And it also depends on what probes are being used. If your FISH probe set only looks for high-risk lesions and you don't have them, your FISH report will come back normal. So that's important to keep in mind. So Dr. Usmani, before he went to LCI, was at the University of Arkansas with Dr. Barloghi, where they really pioneered what we call gene expression profiling. So genes are transcribed into mRNA before they're made into their proteins that execute their function inside the cancer cell. So you can look at the levels of those mRNAs to determine what genes are actually turned on and what genes are turned off. You could have a mutation at the level of DNA, but if it's not turned into mRNA and turned into protein, it has absolutely no functional consequence for the patient whatsoever. So Dr. Barloghi and the crew at the University of Arkansas, took all of their patients and they basically looked to see what genes are turned on and what genes are turned off. And what they found is that there's 7 distinct molecular subtypes that they could identify by this specific technology. And it actually matches very well with the cytogenetic, the chromosome abnormalities that we see as well, which shows you that it's a fairly robust technology. So, for example, you have CD1, CD2 subtypes, which are characterized by overexpression of cyclin D1 with regards to the 11-14 translocation, and cyclin D2 with regards to the 6-14 translocation. The MF subtype is characterized by these two IGH translocations, which lead to overexpression of MAF-B and CMAF. There's the hyperdiploid, which I told you about, 42% of patients. There's the MS subtype, which is characterized by the 4-14 translocation. It's called MS because there's a gene called MMSET that is upregulated as a result of that chromosomal translocation. There's the PR subtype, or high proliferative rate. That's more heterogeneous from a cytogenetic and mutation perspective. And then there's this other, less common subtype called LB. And these patients just clinically very rarely have bone complications of their disease. As it turns out, the proliferative subtype, the one characterized by the 4-14 translocation, MS, and the MF groups don't do as well. Those would be considered high-risk gene expression profiles. So this is pioneering work, that's been spearheaded by the MMRF initiative. So this is basically whole genome sequencing of multiple myeloma, try to determine the genetic profile of myeloma. And this was reported back in Cancer Cell a few years ago. And there's just a few take-home points that I want to make. First, we do see recurring mutations, that are shared by a number of different myeloma patients. That said, they are, fairly heterogeneous. So what you'll see here, and we'll talk a little bit more about this later, KRAS and NRAS gene is frequently mutated in 20 to 25% of patients. BRAF, you'll hear more about that later as well, is a gene that's mutated in up to 50% of metastatic melanoma patients. But it is also mutated in 5 to 8% or so of myeloma patients, suggesting that you could potentially use a melanoma therapy against that specific unique type of myeloma. This is just a small number of the mutations that have been found, but they're the more common ones. The question is how can you develop, tailored therapy for these groups? Well, as it turns out, NRAS, KRAS, and BRAF are all part of the same signaling pathway, so you could potentially employ the same type of therapy for patients that harbor those specific abnormalities. Similarly, inactivation of TRAF3 and CYLD leads to activation of NF-kappa B, which is known to be important in myeloma pathogenesis. So if you could develop an NF-kappa B inhibitor, those patients might, potentially benefit. About 50% of patients who have this type of testing have potentially actionable mutations, and I think that that's important to recognize. However, there are some daunting issues with regards to kind of the genetic landscape of multiple myeloma and the potential for personalized medicine. So this was published by the Mayo Clinic group in Scottsdale, and they basically looked at a variety of different mutations in multiple myeloma. They found the same mutations that I just showed you in the other study, but this is just basically to show you, that the percentage of the myeloma cells that harbor those specific mutations can actually just represent a small population of the total myeloma. So 50% of the mutations that were found were present in less than a quarter of the myeloma cells that were isolated. In other words, these were secondary events. So if you had a BRAF mutation in 10% of your myeloma cells and you employed a BRAF specific therapy for those patients, you may kill off those 10% BRAF mutated myeloma, but the other 90% of the myeloma will be unscathed. So there's been a lot of talk about how multiple myeloma evolves genetically over the course of time. This is one of the first cracks at it. Again, this is from the Mayo Scottsdale group. And they did array comparative genomic hybridization and FISH testing, and they identified 3 types of myeloma evolution over the course of time. So they talk about genetically stable evolution. In other words, when they look at the chromosome profile over the course of time, the missing chromosomes from the beginning are still missing later. Those that are added are still there. There's no new changes. It's the same as it was at the beginning. There's linear evolution, where the original abnormalities are still present, but you're adding new ones on top of what was already there. And then there's the shifting dominance, which represents about 43% of the myelomas, at least in their experience. And what you see here is loss of chromosomal material, gain of chromosome material, and what appears to be reemergence of regions that were previously homozygously deleted, which suggests that there's kind of shifting dominance of clones over the course of time. And that has potential implications with regards to optimal treatment and choice of therapy at relapse. So in theory, you could have, a clone that was sensitive to a particular drug get lost over the course of time, but due to selective pressure as a result of treatment, reemerge later and actually start working again. Although in clinical practice, we don't see that happen a whole lot. This is a really cool study that was done by the Arkansas folks and published just last year. And this gets at the issue of what we call spatial heterogeneity of multiple myeloma. So basically what they did is they took random bone marrow biopsies like we would typically do, and they also did a fine needle aspiration of a dominant focal bone lesion. elsewhere in the body. And they subjected both sites to chromosomal testing, genetic mutation testing, et cetera. And this is the data that they derived with regards to the chromosomes. And what you can see here, so the red, the dark red here are lesions that are not shared by the two different sites. And what I want to point out here is a couple things. So with regards to deletion 17p, and again, I've mentioned that this is a high-risk marker, 2 out of the 6 were not shared. In other words, there were patients that had deletion 17p at one site, but not at the other. And when they did their 70 gene expression profile, out of the 13 patients that had a high-risk gene expression profile, 8 of them had discordant results, which would suggest that if we just do a random biopsy and don't go after that other lesion, we might actually be missing high-risk disease. This is the same study. Instead of looking at chromosome abnormalities, they're looking at specific genetic mutations. And again, I'm just going to focus here on p53. That's the tumor suppressor gene that's present on the short arm of chromosome 17. So again, this is felt to be, the most important gene that's deleted in deletion 17p. And you can see here, there's a couple of what we call biallelic events. In other words, both copies of p53 have been knocked out. Either they've been deleted or they've been inactivated by mutation. But there's a couple of examples here where they're not shared. In other words, there's a biallelic event, a biallelic knockdown that has occurred at one site, but not the other. So if we're not looking for it, we could potentially miss it. This is another example from the same study. So this is just a specific patient who had a hot spot on PET CT in the lumbar vertebra here. So they had this biopsied, and then they had a random biopsy of the iliac crest. And in the lumbar vertebra, which lights up clearly a lot hotter than what we're seeing here, they were high risk by the gene expression profile. They did not have hyperdiploid cytogenetics. They had a deletion of 1p, which is high risk, and they had a biallelic inactivation of p53, whereas over in the left iliac crest, by gene expression profile, they were low risk, they were hyperdiploid, and they had a BRAF mutation. If they had not sampled both of those sites, there's no way that they would have known that this patient had high-risk disease. So let's talk about some of the prognostic systems that we have in place for multiple myeloma. So there's the international staging system. You all are familiar with this. This was intentionally made simple, but I think we've become increasingly convinced that myeloma is too complicated to just use this, so we have different algorithms that we're using these days. But the ISS basically consists of 2 blood tests, the beta-2 microglobulin and the albumin. If your beta-2 microglobulin is really high, you're stage 3. If it's low and your albumin looks good, you're stage 1, and stage 2 is anywhere in between. These median overall survivals are completely out of date. This was derived from patients that were diagnosed from 81 through 2002. Everything has changed dramatically since that time. So high-risk chromosome abnormalities are important, but one of the take-home points that I want you to have here is that it's not just a single high-risk abnormality that's important. It's an accumulation of multiple high-risk abnormalities that's absolutely critical. So this is data from an older MRC study, the MRC IX study, and they looked at the high-risk IGH translocations, 414, 1416, 1420. They looked at deletion 17p, and they looked at gain of 1q. And what they found was if you had no adverse lesions, you did really well, but as you accumulate multiple lesions, you don't do quite as well. And for the ultra high risk patients who had 3 of these abnormalities, their median overall survival was less than a year. Now that's probably changed at this point because therapy has gotten better, but it tells us that those patients are clearly ultra high risk, and we need to learn how to treat those patients better. I said that you have to get an LDH at baseline, and the reason for that is if your LDH is high, you generally don't do as well, and it's just a non-specific marker of a more aggressive proliferative phenotype. The IFM group took a stab at trying to define ultra-high-risk disease as well, just like the MRC did, and what they wanted to do is take clinical parameters, ISS stage, high LDH, and incorporate cytogenetic abnormalities into that. And they developed one of 4 different scores. So score 0 is no risk factors, so ISS 1 or 2, normal LDH, no 414 translocation or deletion 17p, and these patients did remarkably well. So 2 years out, 93% of them are still alive. If you start accumulating a lot of these abnormalities, so you have a 414 or a deletion 17p, stage 3 disease or high LDH, those patients didn't do quite as well. And that's what really led to the revised ISS system that we now use, which employs all of these particular markers. Again, LDH, high-risk cytogenetic abnormalities, and ISS stage. So we incorporate all of those to get a better handle of what the prognosis is going to be. The caveat here is, the high-risk cytogenetic abnormalities that are incorporated here are relatively limited, so deletion 17p is important. 414 and 1416 are important, but there are other high-risk markers that are missed by this. And that's one of the reasons why having a myeloma specialist involved in your care is important, because the devil is in the details. These staging systems are very important prognostically, but they're imperfect, and we can kind of sometimes dig into the weeds and better understand whether the patient truly has high-risk disease or not. These are the MSMART guidelines that are used by the Mayo Clinic. So they basically break it out into not just standard and high risk, but high, intermediate, and standard. So high risk, again, these chromosomal abnormalities, they also included the gene expression profile from the University of Arkansas folks. Standard risk is hyperdiploid, or the 1114 or 614 translocation, and intermediate is all others. And importantly, 414 falls in the intermediate category here. And the reason that they did that is because we know that 414 patients who get treated with proteasome inhibitor-based therapy over the course of time do much better now than they did many years ago. So what was once considered a high-risk marker isn't as high risk anymore. So as treatment evolves, the definition of high-risk disease has to change as well. Gene expression profiling, again, very powerful. Previously, I showed you the data on the molecular subtypes based on gene expression profile, but the 17 gene expression profile signature is incredibly powerful with regards to progression-free and overall survival. Before it was available through Signal Genetics. Signal Genetics gave this to Quest Diagnostics, and it's still a work in progress, so this is not clinically available quite yet. Skyline is another gene expression profile platform that's currently in development, and at LCI we're actually going to have a study launching in the very near future where we get Skyline gene expression profiling on all of our patients at baseline. We make decisions about therapy without that information in hand, with all of the other information available to us, and then the information is made available to us, and then we're asked to determine whether or not the gene expression profiling data would have changed our mind about how we would have treated the patient. So the last thing I want to do here is just kind of tell you that, again, the devil is in the details. So we think we know what high-risk disease is, but it's very complicated. So this is an example of what we call dose-dependent effect of deletion 17p. So this has been reproduced by a number of different groups at this point. And the take-home point is this. Yes, having a deletion 17p is considered high risk, but the proportion of myeloma cells at baseline that harbor that deletion is probably even more important. So in this particular study, they used a cutoff of 50%. So if you had deletion 17p and more than 50% of your myeloma cells, your median progression-free survival is much worse than if it was present in 50% or less of the cells. Similarly, survival was affected by the burden of deletion 17p harbored by your myeloma cells. And different groups have looked at different cutoffs, 20%, 50%, 60%, and there's an ongoing initiative to pool all that data to help us better understand where's the important cutoffs. Not only that, and I've alluded to this before, but not all deletion 17p is created equal. So having a deletion 17p is considered high risk. However, if you look at people who just have a mutation in one of their p53 genes or they have a deletion of p53, but the other p53 copy is intact on the other chromosome, those patients do just as well from a progression-free survival and overall survival perspective as those patients who don't have deletion 17p. It's the patients who have both p53 genes inactivated, either by deletion or mutation, that don't do as well from a progression-free and overall survival standpoint. So it begs the question, are we overestimating the risk that's conferred by deletion 17p? And I think that the reason why the burden of 17p deletion is important prognostically, because the more deletion 17p myeloma cells you have around, the higher the likelihood that that second p53 is going to get knocked out, and that's probably why we're seeing what we're seeing. This is data that was actually derived from the COMPASS data set, which is something that's being spearheaded by the Multiple Myeloma Research Foundation. Comprehensive genomic testing at baseline all the way through the course of therapy, and we're going to see a lot of very important information published in the years ahead with regards to that data set. We talked about 414 being a high-risk translocation, but not all 414 is created equal. So this is again from the COMPASS data set, and what they showed here is that just having the 414 translocation is not that big of a deal. If you have the 414 translocation and if you have a mutation in what's called FGFR3, fibroblast growth factor receptor 3, those are the patients that don't do as well from a survival perspective. Now that's interesting because the 414 translocation actually leads to increased expression of FGFR3, but it's not just increased expression of that gene that's important, the mutation of it as well. Now there are FGFR3 inhibitors that are out there, and there's a lot of interest in employing FGFR3 inhibitors for patients with this specific type of disease. Not all gain of 1Q is created equal, so the dose, again, of the amplification of 1Q is important. So this is from the MRC, and a gain of 1Q is considered 3 copies. Amplification is 4 or more, and what you can see here is that the patients who have 4 or more copies that seem to be not doing as well from a progression-free and overall survival perspective. Lastly, I'm just going to quickly touch on 1114. I mentioned that before, new therapy potentially available for it. We view this as a standard risk marker. However, the Mayo Clinic folks looked at their data set over the course of time, and what they found, suggests that while it's not high risk, it may not be as good risk as they initially were led to believe. So this is progression-free and overall survival for those patients that do not have 1114 translocation, and then the blue line is 1114, and then the dotted line is the high-risk IGH translocations. So what you can see here is that the 1114s are somewhere in between, so we could perhaps be doing better, and we'll be talking more about venetoclax in that regard. So to conclude, myeloma is genetically complex, and this mandates different treatment approaches tailored to the patient's specific disease biology. I think large data sets are going to be important to understand how these genetic abnormalities interact with one another and with clinical, immunologic, and microenvironment factors. Intra-patient, so differences in clones within the same patient. Spatial clonal heterogeneity represent daunting foes for precision medicine. I wouldn't say that it's impossible, but it certainly makes it a lot harder. But multi-drug combinations or mutation agnostic therapies such as immunotherapy may be more effective to control all of the clones present in a patient at any given time. The definition of high-risk disease continues to evolve over time, as I said before, so we'll always have to revisit, whether our definitions of high-risk disease are accurate. And then lastly, FISH is very powerful, but these genomic tests that we have available now can give us so much more information. And I think as these tests become less and less expensive, we'll start employing these in clinical practice as part of our baseline diagnostic testing. And with that, I'll finish up. Thank you.